I would have to say that, again, it depends on the patient. As the monoclonal protein level falls, I find the serum protein electrophoresis less and less reliable because I can't figure out how much is the abnormal and how much is normal. At very, very high levels, you get into problems with what's called saturation, so that the protein doesn't appear to be getting any higher, and you can't. Sometimes there's two protein bands on the electrophoresis, and that becomes complex. And sometimes the band moves, and sometimes it's in the, quote, gamma region, sometimes it's in the beta region, sometimes the beta-gamma region. And so, because of these reproducibility issues, I do like to do both tests, even though it's correct that the guidelines specify a preference in many studies by serum protein electrophoresis.
I just want to add that this point was debated at the international workshop in Venice because of the same kind of problems that we've encountered as well as other of our colleagues in Europe, where particularly now as we move to digital reading of these serum protein electrophoresis smears, it's become even more difficult to be able to look sequentially and have fairly accurate measures given to us. You know, we tend to rely more on the aggregate, the serum IgM level, and you know, one of the modifications that will be forthcoming with the new consensus recommendations is that both should be looked at and followed, and one can perhaps rely on using one or the other in order to be able to assess response, but it is really a valuable exercise to be able to follow both and hopefully see the same kind of trend in both serum protein electrophoresis as well as the total IgM.
At what level does a reduced IgA become a concern for increased infections?
We actually looked at this in a study that we published last year in the journal Hematologica, where we followed patients who had been treated with various chemotherapies, and but we also wanted to know what their baseline IgA and IgG levels were before therapy was initiated. And so what we found there was that the vast majority of patients with Waldenstrom's have low IgA or IgG. So that shouldn't come as a surprise. The reason for this, I have to say, we truly don't understand, despite a lot of inquiry into this. So over time, what we also came to learn is, particularly for patients who got rituximab and fludarabine-based therapy, that these numbers actually deteriorated. And even though patients responded very nicely, we didn't see really a recovery of the IgA or IgG levels. So we don't look at this as being a manifestation of the disease, but perhaps an underlying constitutive process for the patient themselves. And so we also, as part of that study, wanted to look at cutoffs. When did the patient become symptomatic? Because so many patients have these upper respiratory tract infections and sinus infections. And there was really no cutoff that could predict, Bob, at what level the patient would end up becoming symptomatic. And I think that really speaks to the fact that the immune system is really very redundant. We have various armies that battle these infections, and IgG and IgA are just part of that army. And so we weren't able to come up with, set cutoffs. Now, if a patient, on the other hand, has low IgA or IgG, and they are symptomatic and they have recurrent infections, then we will consider in those individuals IVIG appropriately. Certainly the first thing we'll do for those patients is we'll give them antibiotics, we'll do an ENT examination to make sure there's no anatomical obstruction. We'll culture their sinuses to make sure that they don't have a fungal infection that may not be responding to typical antibacterial therapy. But if despite all that we come to the conclusion that the patient isn't benefiting and they have these recurrent infections, then we'll offer IVIG.
I have had one infusion of intravenous gamma globulin, but will now be doing these infusions at home several times a week. Another physician suggested that once each month would be more appropriate.
Well, there's really no data on weekly. I mean, those immunoglobulins half-life is at about 2 weeks. So if you get an infusion today, you will have the drug available. The antibodies are around for about a month. So monthly infusion is reasonable.
make a point in this regard, and that is, as Dr. Treon has said, reduction of uninvolved immunoglobulins, that is IgG and IgA, is very common in patients with Waldenstrom's macroglobulinemia. But many patients with Waldenstrom's do not get recurrent infections on this basis. The vast majority remain asymptomatic. And in our opinion, it's rare, if ever, that we give intravenous gamma globulin to patients on an ongoing basis. There are a number of reasons for this. One, there are side effects with just the infusion of the IgG. It's inconvenient for the patient. There is a national shortage of intravenous IgG, and furthermore, it's a very expensive drug.
The only other point to add to all those well thought out comments is that IVIG can also cause an IgM flare. And so if you are a patient who has a high IgM level, 4,000 or 5,000 milligrams per deciliter or higher, one needs to be very cautious about using IVIG not to induce a flare and become symptomatic.
Okay, here's a question. What is the link, if any, between the Epstein-Barr virus and WM or other autoimmune cancers? I don't know about that latter part of that question.
This has been looked at.
Epstein-Barr.
This has been looked at in a number of series, and there is no definitive link to Waldenstrom's.
Is that a relief to everyone? Okay.
I should point out the same also is true for the hepatitis C virus, which has also been out there for quite a while as being a potential cause. This actually may have a little bit of credence to it. We looked at this in a very large series, both by antibody studies and molecular studies, and the vast majority of patients did not have the hepatitis C virus. But in Italy, they've seen an association with patients who have Waldenstrom's and cryoglobulin. So I think in that particular circumstance, the patient who has the Waldenstrom's and cryoglobulinemia, hepatitis C virus testing should be considered. Morrie, any comments on that?
No, Epstein-Barr virus, Burkitt's lymphoma, that's it.
Okay, question. Actually, a couple of questions. I'll combine. Rituximab and ofatumumab are working, quote, in the same general way. Are there any differences in these agents? And more importantly, are there any differences in results?
So to share our considerations, these antibodies both bind to CD20, but they bind at different positions. So there are some differences in terms of where the Rituxan binds and the ofatumumab binds. That having been said, in most of the studies, the general surmise is that the level of activity for both of these antibodies, whether they're used for the first time or in relapse settings, is about the same as we see, for each other. There's really one circumstance, though, that I would encourage that ofatumumab in particular be looked at, and that is for the patient who is intolerant to Rituxan. In our series, about 10% of patients eventually become allergic or intolerant to Rituxan. And both we at our institution, as well as Rick Furman, who did a dedicated trial on ofatumumab in Waldenstrom's studies at Cornell, have actually administered the ofatumumab antibody to patients that were allergic or intolerant to Rituxan. And we were able, in I think the majority of those cases, to be able to give the ofatumumab antibody successfully. And that's because ofatumumab is actually a fully humanized antibody, and so it doesn't have that mouse portion that rituximab has that occasionally can cause an allergic reaction. I should also point out that you can get the flare also with ofatumumab. So once again, be wary if you're going to get the antibody that you have your IgMs determined in advance.
Why are there so few overweight IWM patients versus the U.S. population.
I don't think that's true.
Notice how I didn't talk about the doctors.
Thank you very much, Morrie, for your As Dr. Gertz goes out the door, another question relating to weight. Does Waldenstrom's cause weight loss or weight gain?
You know, I have to say we have not been impressed by that as being a presenting feature, even though in other lymphomas, and Rafat can certainly comment, it's common to see weight loss, but we don't see that in Waldenstrom's. The same with night sweats. I mean, we'll get the occasional patient that has night sweats on presentation, but it's not really the norm either.
Can be induced by the doctor, the weight loss. Be it the wrong way and they have diarrhea, that's not a good thing.
But sometimes there's a loss of appetite on WM, so
I have to say,
very easily.
yeah, again, that's really not the norm. Not the norm. You'll see loss of appetite or loss of weight in this disease.
What is your opinion on the use of medical marijuana to counter some of
I'm from the Midwest. East Coast guy should answer that.
No, I think West Coast guys should answer that.
The truth is, I mean, I think we do have plenty of drugs that we use for managing side effects. And I think careful, assessment of the drugs for the side effect, benefit, and interaction with other drugs should be weighed. And if the drug, is the, Marinol, that's the prescription drug marijuana, if that's what's going to help, then use it. But I think I don't have any reservation about using the right drug for the right indication.
Okay. Sorry about the answer here, folks.